So SCFE, moving on to questions of this. This is a 10-year-old African-American boy, emergency room, right hip pain, symptoms present for a week. Then in the medical history, they give you the things that are important: hypothyroidism, his weight, he's heavy, and you all have seen the question, and you've seen the degree of deformity, and so what they're looking for is for what reason would you pin the contralateral hip, and all of these are risk factors, being older, severity of displacement, younger, severity of displacement, history of hypothyroidism, and obesity. So I think that's the reason to know these, and then to know that symptoms for more than 1 week would not be an indication for contralateral pinning. So again, the risk factors: obesity, males, African American, Pacific Islanders, average age 13.4 for boys, 12.2 for girls. I think it's probably reasonable to know that it's bilateral in 20 to 50%. And know that the slippage occurs through the hypertrophic zone of the physis. There are often questions about that. I think the endocrine disorders, certainly the renal, but most commonly hypothyroidism. And if you see one in a child less than 10 or very light, that's an indication for an endocrine workup. So they might show you, it might be reasonable, they might show you the hypertrophic zone but not label it and have you pick that. But I think the classifications for SCFE, I think there's simple grading systems we're probably not going to see much more than the grading system of grade 1, 2, and 3, 33% up to 50% and greater than 50%, and then also the temporal classification. Groin and thigh pain, symptoms have been present for weeks to several months, often before the diagnosis is made, and the patient presents with obligatory external rotation. So what you lose in SCFE is hip internal rotation, abduction, and flexion. So if you remember that, I think you can get most of those questions. AP and frog leg lateral, obviously the lateral, the most important, and Klein's line, and actually the more important would be the widening of the growth plate as an early radiographic finding. MRI can help diagnose a pre-slip condition, can help you with widening of the physis, so it may be reasonable. 1 versus 2 screws, I don't think you're going to see too much of that, but with the exception that the chance of damage to the femoral head is greater with the two screw fixation. So contralateral in situ pinning, there tend to be a lot of questions about that. We've been through this: obesity, endocrine disorders, particularly hypothyroidism, and slip at a younger age. It's the most common complication after unilateral surgical fixation. And I think the slip progression is relatively rare. These are the complications, and impingement with residual proximal femoral deformity and leg length discrepancy is one of the most important.
If you enjoyed this video, please consider leaving a like. We'd love to hear your thoughts and what you'd like to see next in the comments. Don't forget to subscribe to our channel and follow us on social media.